of all, at welcoming me back and being patient and kind. So I appreciate them so much. A note for the OSAP recipient meeting, it will be focused on the presentations and tomorrow on the specific grant breakouts and the 3 topic specific breakouts. OSAP will be hosting a webinar in the near future to address allocations and billing. If you have any project specific concerns, please follow up with an email to your program manager and copy Tone. So welcome everybody. I'm just jumping in and being a team player today. So that's what we're doing. That's what we do at OSAP. I think with that, Jay, do you want to say hello?
Yes, thank you, Pamela. Good morning, everybody. Jay Quintana, Program Manager and Acting Seminar Coordinator. Like to say good morning to everybody and welcome you to this year's recipient meeting. Like Pamela had mentioned, I think we were going to have a webinar later on to address billing question or any other questions. I think it was mainly focused on presentations today, but please reach out to me if you have any questions on Seminar tomorrow. I'll be providing the training, our usual training for Seminar tomorrow. Thank you, Heather.
Thank you, Jay. Heather?
Good morning. Thank you both. Good morning, everybody. It's great to kind of see you all digitally, I suppose, and we'll get to see you more tomorrow during the breakouts. We certainly appreciate your flexibility as we're kind of adjusting to the constraints that life presents itself. If you don't know me and this is the first time that you're seeing me, my name is Heather Burnham. I'm a Prevention Program Manager with OSAP. I focus on the Partnerships for Success 2020 and the SPIF-RX grant, but I'm also helping out with the SAPT program while we are understaffed. But I hope you all have a fantastic day and this agenda today and tomorrow help invigorate your passion for prevention. And like Jay said, if you have any questions, please do reach out to us, to your respective program managers, and we'll try and help you the best that we can. Have a good day, everybody.
Thank you, Heather. So now we're just going to move on into the agenda. Our first presentation for today, I'm thrilled to see, is Paula Feathers with Kamama Consulting. She has contributed so much over the years to sustaining the workforce in New Mexico for prevention. So we're glad to have her here today. Miss Paula Feathers?
I'm here. I'm getting the screen set up really quick. Okay, can you hear me and see me, Pamela?
Yes, I can.
Okay,
Hi,
thank
Paula.
you. Okay, good morning. Good morning, everyone. It's so nice to be back here in starting a new fiscal year. I hope that you all are as excited as I am. I absolutely love this work that I'm blessed to be able to do. You all get to go out into the communities and provide amazing services, and I get the opportunity and blessing to provide, which I hope are equally amazing services to you all, our workforce. So if we could do the first poll, this will just help me. I have a relatively short presentation. And so to help me figure out where I want to spend most of my time, I did want to ask you all a few questions. And so if we could do poll 1, please. So if you all would please just take a minute to answer just question number 1, not all of the questions, just number 1. What is your funding source? There's several options there, and if you don't know, that's absolutely okay. Please go ahead and mark that you don't know. I remember coming to the subrecipient meetings when I first started out as a preventionist, and I had no clue what my funding source was. So that's an option. And then I can't see how many people have completed the polls, and so I'll just leave that to the COOP team to show the results for poll 1 whenever you feel like they're ready. Okay, fantastic. So a majority of us have SAPT and PFS 20 funding sources. And so there was some of you like me that didn't know who your funding source was. And like we said, that's totally fine. And then we have some PDO and some SPIF RX. So this presentation is primarily geared towards the SAPT and the PFS 20 grantees. And so as I talk about this information, the training that we develop is geared to help those grants specifically, but we do offer training that is applicable to everybody. And so we'll go ahead and get started. Okay, so just an overview about what the training system is. Let's see, and let's do the second poll question. Do we need to pull that up again? Because I want to talk a little bit about contractual requirements. So we're going to answer poll question number 2 for this one. Okay, so if you could please look at question number 2. As part of your contract, are you required to take training? Again, yes, no, or you don't know. And then Coop Consulting Team, I'll leave it to you to show the answers whenever you feel like it's ready. Let's see. Okay. So a majority of you, 56%, say that you're required to take trainings, and then some of you say that you're not. And so many times at the subrecipient meetings, we have directors and managers who oversee the grant, especially this is pertaining to you if you oversee SAPT funds or PFS 20 funds. But your staff or people that you work with are the ones who are responsible for taking the training. I would like to ask that you please share this presentation with them if you know people who work with you that are required to take trainings. This will be available on the website, and I believe they're recording it. And so it might be, you might be able to share this with other people as well. And so I wanted to jump into what is the training system for some of you who may not be familiar with us. We are funded by the Office of Substance Abuse Prevention, who I'll refer to as OSAP. We're one of the very few states in the entire country who really values the workforce. And so they value the workforce so much that they put resources to it. And we manage those resources in a training system. And we offer 30 training days a year. So between now and June 30th of next year, we'll offer 30 training days. And the whole goal of the training system is to help create effective preventionists for all of our communities. Our trainings gear to providing all of the different skills that you may need based off of the Certified Prevention Specialist credential, which is extensive. And we'll talk about that a little bit more later on. All training that we offer meets your contractual requirements. So you're required to complete a Form AB, and then also a Form C. All of our training system directly ties to those. And I'll talk about Forms A and B in a little bit. All training that we provide, that Kamama Consulting provides through the training system, helps all of you who are working towards your CPS credential. So if you're working to become certified, everything that we offer counts. The continuing education hours are approved by the board, and they help you gain your certification. And our specific, the way that we design our schedule is to meet the goals of the SAPT grantees primarily, because that's where our funding comes from. So the next one is who can use the training system. Everyone has the opportunity to, if you're SAPT or PFS 20, you have the option of attending training for free. Every grantee has a core team, and you can have 5 to 7 people on that core team. And there is a process that you use that's used to, sorry about that, that's used to update the core team every month. And I'm going to share a document let me see if I can do this with everybody. Oh, maybe I can't. So I wanted to share, I'll share a document with you all later on. But it shows the process of how to update your core team list. And the basic process is that the manager or the director or whoever is designated by you sends your core team list of 5 to 7 to Heather Burnham. And that list stays the same unless you decide to change it. So if you have turnover or you have new people who you want to join the core team, you would need to send those names to Heather Burnham. And then the next month, on the 1st of the next month, as long as you get those core team names in before the last day of the month, those will become official the next month. So let's say right now we're in August. If you submitted a revised core team list to Heather, those would become effective starting September 1st. We do, if you do hire new staff and there's a training that's immediately coming up, like let's say that you hired somebody next week and that you want them to take the substance use prevention specialist training that's coming up, but you can't get them on the core team soon enough, you can send us an email and let us know that they're going to be on the core team and we'll work with you. And then our training system is also open to other professionals. And we do charge people who are not on the core team list that OSAP provides us a fee. And that fee is really minimal if you compare it to other trainings. And we're able to do that because OSAP invests so much money into the training system. All right. And the next thing is, how do I take training? I wanted to share our website with you all. If I can just pull this open a little bit. This is our website. And oops, sorry, it's being a little difficult right now. It's at NewMexicoPreventionWorkforce.org. Let me see if I can expand that. There we go. Okay. And here you can find everything that you need to know about the training system. You can find our policies, you can find the registration, and we're on the homepage right now. And I just wanted to share with everyone, in case you are not familiar with our website, that we have several resources available right on the homepage. These particular trainings, if you scroll down, they're called capacity building resources. We offer a naloxone training. It's a really short, condensed training about how to administer naloxone to somebody, and gives you some information about different opioids. And that training is available to everybody, and you can even share it with community members if you wanted to. There's a really cool video on there that shows people what it looks like to actually administer naloxone. So that's available. And then we have, it says OSAP specific online resources. These are 3 other classes. We offer a training on how to use Excel. So this is especially helpful for those of you who might not be as familiar with Excel, and especially now if you're using it to outline your different activities and tasks. And then we have a fiscal management training to help with budgeting and different things like that. Both of those trainings are 6 hours long. You don't have to take the entire 6 hours. You can look at the different modules and say, oh, I want to learn how to do that or that. And you can just go to that section of the training and work through that. Or you can, and then there's also an overview for using the strategic prevention framework. And that one is a really short class, and it just gives you an overview about the framework, which I'm sure you constantly hear about. And I wanted to just take a couple of minutes and show you the registration site. So as I mentioned, we primarily gear our trainings towards SAPT, but we do have a training coming up around that helps with harm reduction, and it's called Preventing Youth Fentanyl Overdoses. And then 2 trainings that I wanted to highlight is they're successfully managing your OSAP contract. If you are new, or if you have staff that are new, or if you've never had anybody look at your scope of work, I would highly recommend that you take this training. This training isn't just for directors or leadership, it's for anybody who has to implement the OSAP scope of work. We have that coming up on September 13th. It's a hybrid training, meaning half of it's online, self-paced within a certain time frame, and then we go live on Zoom and we do some activities. And a lot of people, I actually run that training, and a lot of people who have taken it are just blown away at how much easier their jobs become after they take this training, because we just sit there and go through the contract and we explain things and we talk about things, and you're able to ask questions that you might not have the opportunity to ask in other settings. And then we also have the training coming up. We listen to our evaluation. I'm going to talk about that a little bit later also, but we have our substance use prevention specialist training coming up. And this one is required. So everyone who receives OSAP funding for PFS 20 and SAPT, you're required to take the SUPS. And so this one is coming up. It's an in-person training in Albuquerque. We're going live again. A lot of our evaluation, people were saying, I want to get back into the classroom. And so we've listened to you, and we're really blessed to find trainers who also want to get back into the classroom. And so this one is coming up on September 26th. If you know your learning style is more of you like to be in person and learn that way, I highly encourage you to attend this training. The next time that we offer this up twice a year. The next time we offer this, it'll be online. And so if you're an in-person, learner, I highly encourage you to attend this training. All right, so there's a little bit of our website. And then let me go back to here. Okay. And then earlier I mentioned Form A and B, and this form is due relatively quickly for those of you who have this in your contract. And what I would highly encourage you to do is anybody who needs to take training and complete Form A and B, do it as soon as possible. And what this does, this form serves a couple of purposes. So the first thing that it does is it helps you identify what areas you need to increase your skill level, your practice, your knowledge in when it comes to working towards becoming a certified prevention specialist. And even if you're not working towards becoming certified, just this information and knowing all of the different stuff that you need to know to be an effective preventionist is incredibly helpful. And so it's a requirement. You got to submit this coming up soon. But it's also a tool for you. So after you complete this form, you can go through and look at where do you need help? Where am I not so knowledgeable? Where do I not have much practice? And then use that as a guide to go through and select trainings that are coming up. So if you identify, that you need, that there's some work that you need when it comes to the evaluation domain, which is what we're looking at right now, we do offer an evaluation training every year. You can make sure to sign up for that. So this form helps you in a couple of different ways. It helps you think about your skills as a preventionist. It helps you get ready for the Certified Prevention Specialist certificate, because this is the exact same form that you use in that application. And it helps you become efficient at using the training system to help it meet your needs. And then I highly encourage all of you to reach out to me too and request trainings. A majority of the time when people request trainings, we meet those needs as soon as we can. It usually takes a quarter or two for me to find the right training and get everything situated, but we work really hard when there's requests for training. And we take our evaluation really seriously. And we use our data to work with trainers to develop objectives, to work on different activities. We identify which training to offer, because in our evaluations, we ask you, what would you like to see more of, or, what would you like for us to offer? And we use it to improve our own systems, like our registration processes, our policies and procedures, our communication with you all. And so with that, let's see here. There is another poll. And so I skipped one of the poll questions, but with this one, let's answer poll question number 4. There we go. Thank you so much, good consulting team. So, here we go. If training participants complete the quarterly evaluation, if you could please answer this question. Get to feel good about their contributions to the training system. They provide data that's looked at, or can enter to win a $50 drawing. So which one do you think is true? And then I'll rely on the COOP team again to pull that up when you think you have all the answers. All right, thank you so much. So we have a mixed bag here. You do get to feel, I hope some of you might feel good about your contribution to the training system, which I always do with the evaluation. Those are so incredibly helpful. The second one is absolutely not true. We look at all the data. I have an amazing evaluation team, and they prepare a really thorough report, and our team goes through that thing and we pull out different stuff. But you get the opportunity to win $50. So every quarter, we do 2 different types of evaluation. We do a post-evaluation immediately following the training, and then we do another one quarterly. And at the quarterly one, everybody who completes that evaluation gets the opportunity to win $50. And our last winners were Joanne Griego, Nai Walters, and Orion Zuni. And so we put a little bit of our resources towards those incentives because, like I said, the evaluation means a lot to us. And when you take the training system and you provide evaluation, I just encourage you to be thoughtful about it and know that it really means a lot to us, and we do look at it. And this is my amazing team that I get to work with, and I wanted to share everyone with you all because we interact so much with the participants. We have Noah and Shannon, who are our evaluation team. Like I said, they're amazing, and they provide us really good reports and help our training system continuously get better. They do our website, they do our flyers. They're just incredibly talented. And then we have Miss Contretta, who is so helpful and welcoming and really works hard to create a good training experience for everyone. I thank you all so much for your time, and I will make sure that document, I'll put it in the chat when I'm able to go back to chat later on about the process for adding to your core team. Again, Paula Feathers, and thank you so much.
Paula, there's a question in the chat that I'll read for you.
Yay, thank you, Pamela.
Yes. When is the next substance use prevention specialist training offered online?
Oh, online? Okay. We offer the subs the first quarter, and I'm thinking out loud. That's why I'm giving you a long answer. The first quarter and the third quarter. So the third quarter is between January and March. So sometime between January and March, we will offer the subs online. Thank you so much for your question. I appreciate it.
Thank you, Paula.
Paula, we have one more question in the Q&A. The question is, does training cost the $165 per person?
As long as you're on the core team list. So if you're SAPT funded or PFS 20 funded, you are on a core, you get the option of having that core team, that 5 to 7 members that I mentioned a while ago. And anybody who is on that list gets to attend training for free. And so that's why it's really important for you to update your list if you need to regularly, or to get your list into OSAP to Heather. And then, as I mentioned, you want to get your core team in before the last day of the month, and it'll take effect the next month. So you get your updated core team in now, it'll become effective September 1st. And you just need to keep track of that every month. And then we are willing to work with you all if you communicate with us that I want to be on the core team, and I want to attend a training and I'll be on the core team next month. We'll work with you that way.
There was a couple of follow-up questions in the chat as well, Paula. So the first is from Debbie Ortiz. She asked, is the SUPS training required, and is the cost $600?
The SUPS is required for anybody who has SAPT funding and PFS 20 funding, and like you're a staff member who's funded under those funds, it's required for all of them. Like that's always been a requirement, but sometimes that gets missed. You only have to take the SUPS once. But you need ethics is another one that's required. And ethics, you have to take that at least every 2 years. That aligns with what the credentialing board requires. And it only costs $600 if you're not a core team member. So if you're on the core team, all of these trainings are free. However, our policies are in place to help ensure that we have attendance, that when you sign up for a training, you successfully complete it. So if you are a no-show, like you just don't show up at all and don't give us a warning, you will be invoiced for that. And so that's the only time that it would cost you.
Thanks, Paula. And we have one more question from Jay. Where can providers see their core team list?
Okay, thank you. So I'm going to pull this up on our website. I shared our website with you earlier. And I've never had this many questions. This is like really exciting for me. Okay, so if we go to if we click on training registration, which is where we are right now on this page, if you look here at the very top of the page of the registration, you can see where it says core team right here in the left-hand corner, and it says check here if you are a core team member. You just click on that link. And then right here, it provides you all of the different programs, Carlsbad, the Center for Health Innovation, and it just gives you a list of everybody who's on the core team right now. So that's an excellent question, Jay. I really appreciate you helping me share this free feature of our website. And again, Noah and Shannon really go out of their way to help create a good experience and make things easier. And this was one of their ideas, was to be able to have you all have access to your core teams at any time.
I think that we've covered all the questions. Yay.
Okay. Yay. Thank you all so much for having me.
Yes. Thank you, Paula, for all your contributions to primary prevention, capacity building, and all that you contribute to the OSAP team.
Thank you,
You're
Paula.
much appreciated.
I appreciate that. Thank you.
Yes. And if anybody needs technical assistance, Coop's team is going to put it in the chat. You can reach out to Jennifer, who can help you with that technical assistance. So to the next provider, Allison Stoner with the Mobile Integrated Health from Las Cruces Fire Department will be presenting for the FR CARA grant. Welcome, Allison.
Good morning. Thank you. This is my first time ever presenting in this way, so I think that I'm going to share my screen. And can you all see just my presentation?
So we see your presentation. There we go.
There we go.
Now it's just your presentation.
All right, beautiful. Well, if there are any questions as we go, I would be happy to be interrupted. My priority is just to make sure that questions get answered today. So feel free to stop me if questions come up. It's an honor to be here. Thank you. It's nice to be with everyone this morning. My name is Allison Stoner. I am a licensed master social worker working for the Las Cruces Fire Department, which is a little bit of a non-traditional setting for a social worker. I was actually involved with Las Cruces Fire Department first as an intern when I was in my master's program. So in total, I've been here for a little over 2 years, but working with the opiate overdose outreach program, I've been here for about a year, and I was not one of the original creators. I came into this as it already existed, which has been just incredibly exciting. And I'm happy to be here to share about the work because I love the work. I think that it's a really unique program. We're under the FR CARE grant, the First Responders Comprehensive Addiction and Recovery Act provides the funding. And so I'll just go ahead and kind of get started. If you, like I was before I came into this program as an intern, thought, why does the fire department have, or how does the fire department have programs like this? I thought that they fight fires. It was news to me that the fire department does so much more than fight fires. And so this slide really just sort of depicts that, our fire prevention has gotten significantly better over the years, which is great. But it means that fire departments are responding to a lot less fires and are responding a lot more to medical calls. So with Las Cruces Fire Department, about 6 years prior to the FR CARE grant taking place, Las Cruces Fire Department created a program called Mobile Integrated Healthcare. And this really stemmed from one individual named Paul who said, what are our fire crews actually responding to? And what they found was that it was a lot of low acuity transports. It was really folks, a lot of the 911 calls that we get in Las Cruces are folks who are just needing services. They're utilizing the 911 system for services that they're maybe not linked with that they are needing. So that's behavioral health. That's, we have a pretty large population of older folks in Las Cruces, so a lot of lift assists. And so that's sort of the premise for how this program got started, a lot of high intensity case management. And then the OOO program, that really fell nicely under that umbrella. So as you can see, there is the Facino program, and that's really focused on the high 911 utilizers, the at-risk seniors. The Las Cruces Fire Department is working on a mobile crisis response that's pending. It's hopefully going to have teams deployed come December or January, and that will be kind of an alternate response for mental and behavioral health calls. It will be through the 911 system. But of course, the focus today is the opiate overdose outreach program that I am a part of. And that really looks to serve folks in our community who have substance use disorders or who experience an overdose. And so the goals of that program, what I really appreciate is that if you ask me, the goals of the program are really driven from the individuals in the community themselves, the folks that are receiving these services. But in general, our goal is to reduce and prevent overdose deaths, to provide Narcan and Narcan education to the community and folks that need it. Again, the biggest task for me, which is an easy task, is to approach individuals without judgment and to lessen the stigma. Because what I have found as a social worker is, sometimes social workers might do home visits and receive some hesitance from folks, understandably, that, maybe they don't want to let a social worker into their house. But when the fire department knocks on somebody's door, everyone trusts the fire department. And that's a really beautiful benefit of these types of programs being operated through a fire department. So we're really working with individuals in the community as well as stakeholders to really lessen the stigma. And lastly, we look to refer and connect individuals to treatment services. I did see, I think, a question from Melissa, mobile crisis program development through the 988 rollout. That's a great question. And I'm going to be honest in saying that I'm not sure yet how they will link. The mobile crisis program through the Las Cruces Fire Department is going to be a 911 response first and foremost. I believe that there will end up being a lot of collaboration and overlap with 988. But that may be that the folks from the crisis line end up contacting 911, and then those teams will be deployed in that way. Thank you for your question, Melissa. So a big question that I get anytime I present this information is, what does an average day look like? And I really appreciate that there isn't necessarily an average day, but there are a few things that happen every day. And so if I was to sort of outline what an average or what my constant focuses of work are, it would look sort of like this. I have the benefit of using the 911 system to really find overdoses that occur in the community. And so I use the patient care reports that the fire crews who respond to these calls, I read through those, and I'm looking typically at CPR calls, unconscious unresponsive calls, overdose calls, and we also have the benefit of, I get a notification anytime that Narcan is given by a fire crew. So I take all of that information, I sift through it, I read the reports, and then in that way, I'm able to sort of get a pretty good idea of when an overdose did or did not occur. Sometimes it's unclear, and that's par for the course, that's okay. We will respond anytime that there's an expected overdose. And that's always the way that we approach these situations, to just say, hey, we saw that the fire department responded to this address. We're here to just offer some education, some services, see what might be needed. And that's people are so receptive to that, which again, for me was kind of unexpected. It's beautiful. It's a really incredible opportunity to be able to knock on somebody's door and offer some direct services to them. We will make phone contact if possible, just sort of in the way that the patient care reports are established. It's pretty rare that we'll actually get a phone number for somebody, which is why we typically respond in person first. And then once we get there, once we do make contact with somebody, the range of the services that we offer can look as simple as saying, hey, we offer free Narcan, providing that for them and giving a little bit of training, to the extensive amount of services, like I kind of mentioned, with really intensive case management. So if I approach someone and they say, yes, I had an overdose, I'm looking for inpatient care, I'm looking for medication assisted treatment, I don't have consistent housing, we're able to really support and walk with that person in every step of their recovery. I think that, you know, we all believe that recovery has to be really holistic to be as successful as it can be. So if somebody says, I need to get out of this apartment, we'll work with somebody to make that happen. We really lean on a lot of our community supports and resources to partner, and in that way, we're able to offer quite a few services to folks. And so a part of that is I'm sorry, if I sit too still, my office light goes out. I need to move around a little bit more. We make referrals to services because we are really the middle, the middlemen, if you will. We have a good idea of what services are available to folks in our community. We're not necessarily the best providers for those things most of the time, but being able to get folks connected is really a large part of the work that we do. And I see a couple more questions that I'll go ahead and answer. I am aware of law enforcement assisted diversion, and we do partner with them as appropriate as much as possible. We also work pretty well just with the Las Cruces Police Department. And so most of our work with LEAD has been really to support them. And it's an incredible collaboration to have. I think that LEAD is an incredible program. Thank you for the question. Melissa asked, are you able to provide support on medication? Yes, we do. That's another, surprisingly, I haven't mentioned that I am partnered with a paramedic. And so we really do, going back to sort of that holistic approach, we can, I would say I rely very heavily on the paramedic to sort of walk through those prescription medications, to talk about symptoms of withdrawal, to talk about really the medical side of opiate use, whether that is prescribed or not. So that's a great question, Melissa. Thank you. I do want to highlight a few of our partnerships because they are so important to us. We work very closely with the emergency departments. It didn't take too long once I came into this position to understand, and you add COVID to the table, the amount of just really kind of the crisis that is healthcare that we're witnessing right now. A lot of times folks go to the emergency room for a medical clearance to then go to a more definitive care, whether that's inpatient treatment or medication assisted treatment. And oftentimes folks go into the emergency department and they'll end up discharged and maybe not to definitive care, not with the referral that they were hoping for. And so a lot of times we sort of adapted and said, okay, let's respond to an overdose, and we'll go and we'll have a conversation depending on the situation. And if that, especially if that's an individual that we've maybe already been in contact with, we will just go with them to the hospital. And again, having that knowledge of the resources available in our community, I get intimidated, talking with doctors and navigating the healthcare system. So I can very easily empathize that somebody who's at maybe one of their lowest lows and is experiencing an overdose, it's very hard to ask for what you need in a hospital setting at times. So we go and we have those relationships established, and we have the opportunity to talk with somebody bedside and really hear where they're at and hear what their hope is for a care plan, and then advocate on their behalf. So that's been I think a really beneficial aspect of the services that we can provide. And that has been a direct link to those inpatient facilities Something else that the fire department sees happen pretty frequently is that folks will call 911 from inpatient settings to then have somebody transported to the emergency department. And so for us, myself and my partner, if we're able to sort of intercept, and if we can make that transfer from their inpatient facility to the emergency room and then transport them back, it saves the resources, the 911 resources, and it also is just, again, that link for getting folks the care that they are really needing to address recovery, because understandably the emergency department isn't always the place where that can happen. We get folks linked with medication assisted treatment pretty frequently. We have the great fortune of being able to provide rides to folks, not consistently. We always try to link them with a more sustainable method of transportation first. But if somebody calls me and says, hey, I'm going to miss my appointment today if I don't get a ride, or this ride fell through, or whatever it might be, if our schedule allows for it, we can take somebody directly to their appointment and take them back. Again, I mentioned, right, working through the fire department, working with a paramedic, healthcare in general, and definitive care for folks is huge. And so even if somebody says, no, I'm not ready for inpatient care, I'm not ready for medication assisted treatment, but I have this wound that I'm pretty worried about. Again, the paramedic will step in, and something that we can do is then just link to primary care to make sure that folks have the resources that they need for living their most well lives, right? Really focusing on the wellness of people. I see a comment that somebody loves the Community of Hope. I completely agree. They are an immense resource for us. The Community of Hope in Las Cruces is a shelter for folks who are unhoused, and it's more than a shelter. It's really just a pod of resources. They help folks get linked to housing. They have a health center on that campus. The providers there are really wonderful and intentional. And so they're really our go-to anytime that somebody might be looking for housing. We can get folks hooked in with food and food resources. And then I put knowledge resources on here. I did want to highlight that substance use work I didn't anticipate to be here. And so this has been an incredible learning opportunity for me. And I have found so much benefit in being able to just talk with folks in our community, with stakeholders in our community. And so I get on any meeting that I can to try and just learn more, discuss with folks about trends. There's an opioid 360 collaborative that we have participated in, which is just, it is a wealth of knowledge. And so those are huge benefits to this program. And I see that Melissa did make a comment that Memorial Medical Center is lined up to provide MAT. That is true. It's been a little bit of a work in progress for those connections to really be made. But we're so excited to see it really take off and to just be another added resource for folks in the community. I do want to be conscious of time. So I'm going to go through the data fairly quickly, but I just wanted to highlight a few things. July 2021 was when I began this work. At the time, we were looking at about 130 calls per month. We were seeing anywhere from 20 to 30 opiate-related overdoses, which I know it's a pretty broad, that's a pretty broad range, but it really, we did see quite a bit of variation month to month. Typically, we're successful in making contact with folks between 50 and 75% of the time, and a successful contact just meaning that we did reach the individual that we intended to reach. We were able to offer services whether they were interested or not. And one of the challenges you can see on this slide that every once in a while we're unable to make contact due to insufficient information. So that can be that there was an overdose that occurred maybe at the detention center. We see that fairly frequently. And that's not typically an area where we're able to provide any follow-up. It's an area that we're looking to establish and continue to establish stronger partnerships. But that's a work in progress. Similar, we've also seen quite fairly frequently that folks will come into the Las Cruces community. Maybe they were visiting, whatever it may be. But sometimes we attempt to make contact and nobody's there, nobody answers. Typically, we'll try anywhere from 3 to 5 times to make contact with the individual before we say, okay, we have to sort of move on for right now, but we always keep the names on our radar to potentially come back to. At the start of the year, we were seeing about, February was kind of an exception. It's a shorter month. I was out with COVID, so we did have less interactions overall. We were looking at approximately the same number of calls, and in around the start of the year is when we also started to say maybe that just looking at successful contacts was not the most reflective. It wasn't the most reflective depiction of our work, because sometimes we might be seeing somebody every day for a 2-week period of time. We're helping them get housing, we're helping them get food. And so around the start of the year is when we started to really look at how many outreach efforts are we making? How many times are we taking folks to their MAT or to primary care, whatever it may be. So you get that sense of the work on this slide. I see that I have a question. Are these services, partnerships, resources only available in the Doña Ana community? That's a great question. That is probably if I had to say a negative of being linked with the fire department, we are actually limited to the city of Las Cruces. If somebody comes to us from the county for information, if somebody from the county comes to the fire department to receive Narcan, then of course we are providing those services, but we are not currently doing any outreach into the county. We are unfortunately limited to the city's barriers. Are there people we should be linking with? Grant County for promotion of resources? That's a great question, and I'm going to put my email in the chat later when it's easily accessible. I'll provide my email address. I would love to continue these conversations. Please, anyone at any time, feel free to reach out to me to just continue. Or if there's more questions, I'm happy to have conversations with anyone anytime. And I think that talking about county resources would be phenomenal. And lastly, I wanted to highlight kind of what things are looking like currently. We are reviewing more calls just because our reporting system has changed. And so it's a little bit, to make sure that we're getting the full scope, that we're seeing the whole picture. We're looking at a few more calls, but we're actually seeing less opiate-related overdoses really for the past couple of months. I would say starting in about March, we noticed that overdoses were slowing down a little bit. July has been a little bit, July and then now into August, we're seeing things start to pick up a little bit. But in general, there had been a reduction compared to 6 months ago and definitely compared to a year ago. Yeah, so we're continuing our outreach efforts. We're always providing Narcan. We participate in community outreach events as much as possible. That's really our way to kind of, just make these services more as available as possible. And sometimes that's word of mouth. We do get a lot of folks who will call us and say, hey, I got your number from my friend and they said that you provided Narcan. I was wondering if we could get some as well. And we're always willing to do that. That's the connections with the community are are absolutely fundamental. And that includes the connection to the folks in our community that we are serving. So, all right, I see one more question. Are there more overdoses related to methamphetamine, or are overdoses decreasing overall? That's a great question. And I was really curious if the potential reduction in opiate-related overdoses that we were seeing, I don't know that this is true. It is speculation on my part, but it seemed to be kind of in line with when cannabis was legalized. And so that was a big question for me. I can't confirm or deny that that's true, but I thought that it was interesting that we started to see fewer overdoses around that time frame. I would say, and I would have to look to be very specific, that we're not seeing an increase in any overdoses related to methamphetamine at that time. I'm sorry, I'm seeing that the question in the chat is, are there more overdoses related to methamphetamine, or are overdoses decreasing overall? I'll restart my answer to that question. Overdoses are decreasing overall. We look specifically at the opiate related overdoses, but that's a great question. And I will say that in my work throughout the past year, fentanyl has been the most prevalent substance, which again, this work is relatively new to me, but was a huge change based on the information from my paramedic partner who's been doing this for about a year longer than I have. He said when he started the program, he was seeing significantly more heroin, and we almost never see that in Las Cruces anymore. It's been a really stark shift to fentanyl specific. And yeah, so those are some general trends that we've seen over the course of the last year or so.
One more follow-up question on that one, Allison, is Stephanie Reynolds asks, is that specific to Las Cruces or throughout New Mexico?
That's a great question. It does, let's see, it looks like Bernie provided a response that says, depends where you are, 3 ODs in 30 minutes in Grants 2 weeks ago, 5 ODs this week among prisoners in Otero County Detention Center. So I feel like that's that is a pretty good answer to that question. That it does seem like it's county dependent. I think it's been interesting, something that we've also seen in communication with folks in El Paso is that Las Cruces is just sort of seeing a delayed repetition of the trends that happen in El Paso. When things slow down there, give it a couple weeks and they've slowed down here. When things pick up there, give it a couple weeks and then they tend to follow that same trend here. So I hope that answers the question. I think in general, we've seen fentanyl across the state significantly more than in years past. But in terms of what's happening month by month, it's a little bit more dependent. Any other questions from the chat or anyone that I can answer? Okay. Thank you all so much for your time. I really appreciate it. And again, I'll include my email address in the chat. Feel free to reach out anytime.
Allison, thank you so much for your presentation. Was there a comment?
I was just going to say, I'm sorry to interrupt, Pamela. Allison, thank you so much for the information. And Valerie had a question about your program, if it was available in other communities. And Melissa and I have been chatting. She wanted me to read out loud that the FR Care Grant has a similar program in Santa Fe and also in Gallup. And then a state overdose education coordinator, Bernie Living, also offers support for fire departments who want to build an overdose survivor program. So hope that answers your question, Valerie. And thanks again, Allison. Sorry to interrupt.
No problem. Thank you all very much.
Yes, thank you. Thank you for the work you're doing in your community, Allison, and sharing your expertise. We appreciate it. So next on the agenda, and then after this presentation, we'll be taking a break. Next on the agenda is FY22 New Mexico Community Survey results. Presenting are Liz Lilliot, Dave Curry, Marissa Elias, and Ashley Simmons Rudolph from the Pacific Institute for Research and Evaluation, as we call them, PIRE. Thank you all for joining us.
Thank you so much, Pamela, and thanks for the introduction. Let me pull up my screen and we can get going. Just and keep an eye on time. Let's see, since we are the barrier to your break, we'll try to keep it stay within our time frame. Okay. All right. Okay, I'll just jump right in. Welcome, everyone. I can't see you all this morning, but it is good to be here to give this presentation to you all. As Pamela mentioned, my name is Marisa Elias with the PIRE team. Here with me today is also Dave. Dave, do you want to introduce yourself briefly?
Sure. Hi, everyone. Dave Curry with the evaluation team. Glad to be involved today.
Thanks, Dave. And then also with us today, Liz and Ashley. Liz and Ashley, do you want to say hi real quick?
Hi, everyone.
Great, thanks. So the PIRE team will be helping me keep an eye on chat for any questions. If we need to stop and take a break to address something, we can. But I will try to get through the presentation so that we can cover everything in the amount of time. And then, of course, anything we can't address today, we are always happy to answer questions by email or as a follow-up. Feel free to reach out. So before we get started, I did just want to take a moment and from the bottom of my heart, thank you all. Thanks to OSAP and community partners for making the New Mexico Community Survey possible this year. We acknowledge and recognize that there were a few bumps along the way for a lot of different reasons for a lot of different people and communities. So I just want to thank you all for your efforts and for supporting this effort. Today we'll be sharing just some initial highlights and impressions of the 2022 state level results. We will be finalizing and sharing a summary report pretty soon, which will have more specifics so you can have a closer look at what those results look like. And to my PIRE team, please, as we go along, feel free to jump in and add if I miss anything, if I'm moving a little too fast through things. I did also want to recognize other members of the PIRE team who support and help us out with the community survey every year. Maria Elena Reyes, Emily Houses, Kim Zamarin, Cristina Lopez Gutierrez, Lei Zhuang, and from time to time we still count on Martha Waller's support as well. So just to give a little brief background, a lot of people here today are familiar with the New Mexico Community Survey. It might be something new for some people. So just to give a brief background, the New Mexico Office of Substance Abuse Prevention funds the implementation and evaluation of prevention efforts across the state. To inform these statewide and community level efforts, prevention partners came together to develop a community survey for adults that is referred to as the New Mexico Community Survey, which is what we're presenting about today. This survey is collected annually during the spring. It's collected in collaboration with PIRE, OSAP-funded prevention programs, and other NMCS prevention partners around the state. And this survey focuses on the misuse of alcohol and prescription drugs and some of those contributing factors related to misuse. In addition, communities can choose to administer modules that are related to topics like mental health, tobacco, marijuana, opioids, methamphetamine, polysubstance use, gambling, and adverse childhood events. And just briefly to give everyone an idea of the state level approaches that PIRE leads, we did use social media, both paid and unpaid ads to help us recruit participants. We also provided printed materials in the form of flyers, posters, and smaller postcards that were shared with the different partnering communities that were implementing the community survey. We also engaged a paid Alchemer panel. Alchemer is the survey platform that we use for administering the survey this year. And we also engaged with AdWallet to help us with that recruitment. Again, this is the state level approach led by PIRE. It is our recruitment is enhanced and supplemented and supported by the community level efforts as well. So each community engages in their local efforts to try to recruit participants at the local level as well.
Marisa, you're breaking up a bit. Can you try to speak into the microphone?
Yeah, let me, is this better?
Yes.
Okay, thank you, Liz. Okay, and so just to give you a snapshot of kind of how it went down this year, 91% of the surveys of our sample were completed online this year. And 9% of the surveys were completed hard copy paper. So again, going back to that local level support that we get in recruitment, we did collect some paper surveys this year, which is really exciting. Our total sample size came out to 13,283 participants, which we're very happy about. And really grateful to have the support to meet our goal once again this year. Just some things to take into consideration as far as changes in the community survey for 2022. We know that the situation with the pandemic, the environment and the context with it is not like it was in 2020, but we do recognize that the environment is still not what it was pre-pandemic. And also for that, not even necessarily what it was last year when we were collecting the community survey. And this is seen in some of our results. So we did want to acknowledge that while the COVID-19 situation has seen improvements in some areas, our communities still feel the impact of the pandemic in a variety of ways, and in some communities more than others. So we did want to acknowledge that. We also wanted to note that we did transition to the Alchemer survey platform. We used to administer the online survey through a platform called Qualtrics. So we made that switch to this new platform. We acknowledged that it was a little bumpy at times, as one might expect with a big change. And while it maybe wasn't as perfectly smooth as we would have liked, we did want to say that it still couldn't have been possible to meet our goal to collect surveys without the support and the patience and the grace that we got from all of you. So we want to thank you for that. And lastly, there were some changes to the core component of the survey. The core component, I know I kind of went through it kind of fast earlier, but the core component, the core module of the survey is those around 40 to 43 questions that is required to be administered by everyone implementing the community survey. There were, so as I was mentioning, there were some changes, there were some additions to the core and some slight wording adjustment in some topics.
Hey, Marisa, still going a little in and out. If you just lean more towards your mic.
Okay, sorry about that. Okay, I will try to get up close and personal. Okay. And some other considerations when looking at our 2022 results, not just at the state level, but also at the community level. There were changes, as I mentioned, to the core survey. And in some instances, there were a few errors in skip pattern and other online programming that we noticed either kind of along the way and we corrected as soon as possible, or in looking at the analysis. And specifically, we want to say that this did have an impact on the prescription, on some prescription painkiller questions, and that we did end up with a smaller sample size for some of those questions as a result. The other thing is there was a programming error that we picked up on with the PFS 20 module administration. So this would mostly impact communities with the PFS 20 funding who were implementing that module. Does my sound better, team?
It's still sort of coming in and out, unfortunately. So,
Okay, sorry about that.
just like that.
Okay. All right, let's get to it. So we are going to show you just some initial impressions from the core module of the survey. All right, so starting with the sample demographics. As far as age is concerned, most of the sample is distributed between that 31 to 70-year-old age group. So that means we did see that minors and young adults between the ages of 18 to 25 were underrepresented, a little under 10% of the sample, and as well, and the same with elderly adults, so that's 71 plus age group. As far as gender identity, respondents who identified as males were underrepresented, as about 66% of the sample represented female gender identity. As far as education, 70% of the sample had some college or above. So highly high education sample. And lastly, we did see a slightly lower percentage for participants who identified as Hispanic or Latino, Latina, at about 46% of the sample. And just wanted to know, so state estimates are weighted by race, age, and gender. We did want to note that while weighting can adjust for some distinctive factors about the sample, there are some things that it can't, and this is true for all surveys. So just keep in mind that participants largely, the participants of this year's sample, most of them were recruited online. So this, represents participants who were willing or able to complete the survey online. And also just to note that these estimates are meant to help us understand the state level status and changes during this pandemic. Our New Mexico community survey results are really helpful for helping with planning and making adjustments, but we do encourage you to use it as a complement to other sources of information that are available as well, to have a good idea of kind of what's going on with substance use behaviors. Okay, so jumping into alcohol use. So just a quick summary. We did see that past 30-day alcohol use did remain high during the pandemic years, with very little change in the last year. And binge drinking and driving under the influence did see a decrease, at least since the start of the pandemic. So we'll take a closer look here. In this graph, we are looking at alcohol use, past 30-day use. We are looking at a percentage of participants who were binge drinkers, and then also looking at percentage of participants who reported driving under the influence in the last 30 days. So from left to right, we're looking at the changes from 2019 to 2022. Starting at the very top, the line at the very top, the green line represents past 30-day alcohol use for the total sample in 2022. So this last cycle, we had 52.2% of participants saying that they had consumed alcohol in the last 30 days. That did see, as I mentioned, a slight increase, especially from 2019 to 2020, and still seems to be increasing a little bit since 2020 to 2022. The line in the middle, which is the blue turquoise line, represents binge drinking in the past 30 days. That hasn't changed too much since 2019. And same with driving under the influence. Even though it didn't change too much in 2022, it was slightly lower than what it was in 2019. This is a very similar graph, but here we're looking specifically at binge drinking and driving under the influence just among participants who said that they had consumed alcohol in the last 30 days, which we refer to as current users. So the top green line is the past 30-day use, same as the last slide, but just here for reference. The middle line, the yellow line, represents binge drinking in the last 30 days among current users. If you look from 2019 to 2020, there was a dip. There was a decrease from 35% to 30%. Since 2020, since the pandemic, that percentage hasn't changed a whole lot. And then lastly, driving under the influence in the last 30 days among current drinkers. Again, we did see a dip from 2019 to 2020, from 2020 to 2022, a little bit of a decrease. Okay, and then here we are looking at participants participants were asked how likely or not they thought it was for these different things to happen in their community. So looking at the chart, each of the bars represents a year. From left to right, it goes 2019 to 2020, with the percentage of participants who answered it was very likely. So starting on the left, it's very likely that police will break up teen drinking parties. The darker shade is 2022 at 13.2%. That did see quite a decrease from 2019 when it was 18.1%. The middle is very likely that police arrest an adult for providing alcohol to a minor. Similar thing, we do see a decrease in the percentage of participants who say that is very likely to happen. And then the same in the last is very likely to be stopped if driving intoxicated. Saw a decrease from 2019 at 30% to 2022 at 23.4%. So we don't have a whole lot of time today to get too much into the weeds, but we do encourage you to take a look when you do receive the summary report, and also in your local reports. Take a look at also what stood out was the percentage of participants who said that they don't know, and how that's changed over time. I think for the state level, we saw that in the 20s for percentage, which was really interesting as far as, and to take into consideration, right, again, who the sample is and who would know about these things. So just something to consider, yeah, we'll keep going forward. Okay, and then perceived access to alcohol by teens and minors. This is participants, again, who, similar to the last one, but who answered, they thought it would be very easy. So when asked how easy it would be to access alcohol by teens in the community, looking at the left, the percentage who said it was very easy in 2022, 35.8%, thought it was very easy for teens to access alcohol in the community. As you can see, from 2019, there was sort of a dip, kind of going back up from last year to this year. In the middle, we're looking at very easy access to alcohol by teens from stores and restaurants. The good thing is that is much lower. It's not that easy for them to just go into a restaurant or to a store and access for teens, but there was a little bit of a jump from last year to this year, from 6.2% last year to 8.3% participants who said they thought it was easy, very easy. And then lastly, looking at self-reported providing alcohol to a minor in the last year, that percentage saw a little bit of a slight increase kind of through the pandemic years compared to 2019, but it seems to be kind of going back down and almost to what it was in 2019. moving into prescription painkiller use summary. Before I switch topics, I just wanted to give a sec. Pyre team, are we good? Any questions or that in the chat that we need to address?
We're all good so far.
Great, thanks.
But folks, feel free to put your questions in the chat and we can pitch them to, or try to answer them ourselves or pitch them to Marisa.
Yeah, thanks, Liz. Okay, so moving into prescription painkiller use summary. We did see an increase in prescription painkiller access. That's the question about receiving a prescription painkiller in the last year. As far as past 30-day use of prescription painkillers, we did continue to see an increase, at least since the beginning of the pandemic. We did note that provider education has generally seen an increase, but we did notice co-prescribing of naloxone decrease a little bit from last year. And pulled from the opioid module, we did note that there was high support for public funding for opioid treatment programming. So we'll jump into that a little bit. Here we're looking at past year access and past 30-day use. So past receiving a prescription painkiller in the past year is the top line in the light green turquoise color. In 2022, we had almost about 23% of our participants saying they received a prescription painkiller in the last year. That did see an increase from 2021, but still a little lower than what it was in 2019 and even in 2020. And then the bottom line that you see there is the percentage of participants who used prescription painkillers in the last 30 days for any reason. That started to see an increase from 2020 to 2021 and continued to increase slightly in 2022. As far as provider behaviors that we capture in the community survey related to prescription painkillers, we're looking at a comparison of 2021, so last year and this year's results. Starting on the far left, as I mentioned, co-prescribing naloxone saw a little bit of a decrease. And then moving to the next, healthcare provider talked to a patient about risks. That saw an increase. Healthcare provider talking about safe storage also saw an increase. With the pharmacy staff, for those same questions, we did see a little bit of an increase, maybe not as much as we saw it in healthcare providers, but still for talking about pharmacy staff talking about risks, there was a little bit of a jump up. And then with staff talking about safe storage, actually didn't see change. It was, and I had to double check that because I thought it was a typo, but it's still at 26.3%.
Marissa,
Yes.
I'm gonna read a question from Shelley Mueller. How does the sample of this year compare to 2019 through 2021 with reference to age, gender, race, ethnicity, education, sort of overall demographics?
Thanks, Pamela. Yeah, so that's a great question. I think I can share a little bit and then I'll invite my Pyre colleagues to also fill in. But I think one of the big things to take into consideration is the online component of the participation. Before the pandemic, we did count on a lot of local face-to-face survey collection, so that makes a difference also as far as reaching populations that are not necessarily going to be able to access or take the survey online. So that's one thing. I think, as I mentioned, which I think, if I remember correctly, is true of at least the last couple of years, with the education level of participants has generally been higher and overrepresented with education college or above. And let's see, Dave, Ashley, Liz, what else would you add?
think you hit on the key things, Marisa, because the key reason being that the weighting on race, gender, and age does tend to equate for issues that have to do with those types of demographics, but it does not account for issues around what Marisa was mentioning that really are very much tied, I think, to the difference between 2019 and during the pandemic in the degree to which we have, we're relying on online participation, and therefore people have to be comfortable participating online and are largely recruited online. I think, Marisa, I think you hit on exactly the issues that I would note.
Mhm. All right. Thanks, Dave. Thanks for the question. And I think, and as I mentioned earlier, we will be sharing the summary report once it's ready and finalized soon. And you'll be able to take a closer look. And as I mentioned, if you are taking a look and have any questions or want to chat about any of that, the Pyre team is happy to do that and take a closer look at anything in particular that you're interested in. All right. Okay, and then just some more sort of snapshots from the prescription painkiller as far as perceptions go. So we did see that of the sample, 56% of the participants perceived great risk with misusing prescription painkillers. 79% of participants agreed or strongly agreed that their community is not doing enough to prevent opioid misuse and addiction. And 86% of participants agreed or strongly agreed with supporting increasing public funding for opioid treatment programs in my community. One quick note I'll make is as far as the perception of risk, the top bullet, that was a question that was included as part of the core. So it was asked of everyone who participated in the community survey. The following two bullets were part of the opioid module. So this is only representing participants from counties that engaged that module. So that's why the sample size for those is smaller. All right, moving on to some other questions covered in the core survey, and I believe actually one of these, well, maybe I think both of these were I think part of the module. So on the left, you will see driving under the influence of marijuana is a problem in my community. Yeah, so both of these are from the module, the marijuana module. So you'll see the percentage of participants that strongly agree, strongly disagree, not sure, and agree. So in the orange, 24% agree that driving under the influence of marijuana is a problem in their community, 16% strongly agree. Something that stands out is the not sure. 46% of the participants were not sure if it does or it doesn't. On the right side, also standing out is the not sure. As far as supporting local efforts to prevent marijuana use by teens, there is, somewhere around 60% of participants who did agree or strongly agree with supporting, but there is still that 25% who are not sure. And so we just thought this was interesting and might be helpful to consider, especially for any program who's addressing marijuana prevention for teens, just that there might be an opportunity there for providing information and education about the potential harms or the impact of marijuana on teens. Moving into the mental health module results. So here we're looking at two items from that module. On the left, met the critical thresholds for a serious mental illness. On the right, self-identified having mental health or drug or alcohol problems in the last year. And this is looking at the changes over time from 2019 to 2022. For both of these, we did in 2020, when we gave this presentation, we did see sort of that alarming increase, right, in both of these items. So for meeting the critical threshold for a serious mental illness, from 9.8 to 14.8% from 2019 to 2020, and then self-identified having mental health or drug alcohol problems in the last year, 22% to 35% in 2020. Fortunately, that didn't continue to increase over time. I will acknowledge that the mental health module was collected in 6 counties this year, and it's not necessarily the same counties that have collected in previous years, but still, we just thought this would be kind of a helpful snapshot of just where these things, how these things look, and especially in the context of the pandemic years. And then 3 more items. So on the far left, suicidal thoughts in the last year, from last year, that started to see a decrease to 9.2% in 2022. As far as seeking help on mental health or drug alcohol problems in the past year, seeking help saw a little bit of an increase from last year to this year. And something that stands out there, though, is that had a big increase in that first year of the pandemic as well. As far as having difficulty accessing treatment for mental health or substance abuse problems in 2022, it was almost 10%, with seeing a decrease from last year as far as experiencing a difficulty accessing treatment. So that's it seems like a good thing that there wasn't as much difficulty as reported as last year in that sense. And I think I'll pass it on to Dave to wrap us up.
Okay, thanks, Marisa. I will let this slide speak for itself, I think, because we are getting near the end here. In fact, we're over. But what I do want to repeat is what Marisa said at the beginning, is how much we thank you all for your assistance in helping the community survey to succeed each year. We very, very much appreciate that. And it is really integral to our being able to provide these estimates for the state and for you all, and all of the data that's collected to help you do what you do in your communities and help the state think about these issues. One of the main things that the community survey provides is really timely information, because we do this each year, and it's not a small undertaking, and we realize it's not at all a small undertaking for you all. So we thank you. But with that, I think I will let the conclusions on there speak for themselves.
Thanks so much, Dave. And yeah, if anyone has any questions, feel free to reach out to Dave and I, and we are happy to provide any additional information. And like I said, keep an eye out for a summary report and then a more comprehensive report to be shared in the future.
Are there any questions for Marisa or the PIRE team? So there's one comment from Shelley. I'm wondering if PIRE has discussed adding a module on stigma of SUD.
Yes, Shelley, I'll answer that. We started discussion about that last year, and we kind of came up right up to the moment to say go. But we certainly encourage you all to work on that and to participate in that. And I know that Shelley has been thinking about that for a while as well. So definitely, because stigma is part of the outcome objectives of a number of our discretionary grants in particular. So it would be good to have.
And I will note that our process over the last few years has been to review what changes or additions, adjustments might make sense basically about this time each year with the local evaluation group. So your local evaluator should be represented with that. And any thoughts you have about some of these things, this is exactly the right time to pass it on. You can pass on those types of suggestions either to us directly or to any of the local evaluators who participate in that group.
Okay. Hire team, thank you so much for your efforts on the community survey and for presenting today. So right now we have promised a 15-minute break. So if it is okay with Alicia Campbell from New Mexico Department of Health, we will give her an updated start time. Let's see, I'm gonna of 10:50, and everybody take a break, and we'll convey back here at 10:50 with the 2022 substance use epidemiological profile from Alicia Campbell, New Mexico Department of Health.
Hi, everyone.
Hello, Alicia. Thank you for your flexibility.
Yeah, of course, of course. Whew. Super nervous. I always get nervous every time. I don't know why, but I do. And this time it's a little bit more because I think that Andrea's probably told you that my my internship, I've invited them to join. People who were from my internship that I'm hoping to connect you guys with. So fantastic people here in Houston. So yeah, they're going to be on too. So.
Well, your volume is perfect. So
good. You guys can hear me. Everything, the lighting is good. I'm in Houston, so I'm not in my normal environment. So I feel like I feel like everything is kind of falling and not where I want it to be. So, all right.
Okay, everybody, welcome back. Thank you, Alicia, for your flexibility. We're going to continue with the 2022 substance use epidemiological profile. Take it away, Alicia.
Hi, everyone. So I'm Alicia Campbell, and forgive me while I try to get kind of organized here. I am with New Mexico Department of Health, and we are going to have someone else share the presentation for us, right, Andrea? Go back up one page if you don't mind. Okay, so this is the annual presentation that's given by the substance use epidemiology section for the New Mexico Department of Health. This is the 2020 data. It's a little bit delayed due to the data that was provided, delayed from the state. Normally we get it a little bit earlier in the year, and we're able to provide this presentation to you guys sometime earlier in the year. But this time that we're giving it to you now in August, I think normally we give it to you in April, but we're giving it to you now. So although we are midway through 2022, we hope to have 2021 data available sometime in the next few months. So keep your eyes open for that. Next slide, please. So just kind of a quick overview of what is inside of the profile. And what we have available is we have a consequences section that has our alcohol-related deaths, hospital discharges, smoking-related deaths, drug overdose deaths, and overdose-related emergency department visits, suicide deaths, and then we have a mental health section, which has our adult and youth mental health sections. And then we have a consumption section, which are adult and youth alcohol, illicit drugs, and tobacco sections. These are separated from our surveys and our death records. So our consequences sections are going to come from our death records. Our mental health consumption are going to come from our survey sections. So new sections that are included this year, which is great. We spoke with Coop and with Karen before she left, so BHSD, to kind of talk about some new sections that would be really great, that would be useful for the community. And we decided as a team, so New Mexico Department of Health, BHSD, and Coop Consulting really kind of worked together to decide what would be beneficial for everyone. And so the fentanyl involved deaths, the polysubstance and cannabis use and e-cigarette use are new sections that are going to be in the profile this year. So that profile, just so everyone knows, was uploaded to the substance use, the substance use epidemiology profile section page, and is available for everyone right now online. So if you're looking for it, it's there. Depression and the youth survey sections were not updated this year. Those the youth survey sections are not updated during even years. It's only in odd years, so the next one will be next year. And the updates and changes in reporting, the last ones were in 2019, and those were the alcohol reporting death index from the version 2 to version 3, and the youth pain medication question, which was from taking medication that was not yours to using to get high, all changed in 2019. So those are the only changes that happened, and that was in 2019. So those happened in the last profile. But if you're interested in more information on those, that data is available in the profile under that section, and you can look that up. So next slide, please. All right, so just a little bit more information in how we report the data that we provide. So we do use 5-year aggregate data when we're talking about deaths and ED visits and hospital discharges. Gives us a little bit more stability. It's rates per 100,000 population. So when we're talking about rates, we're looking at, how many people within the population. When we're looking at surveys, so when we're looking at this YRS and the BRFS, we're looking at percentages or estimated persons per population. We do have maps, which correspond to what's called a chart 2, which are within majority of the indicators. I think the only one that's maybe missing a map is the polysubstance, which is a new indicator this time. And the only reason why we took that one out was because it would be overlapping so many of the other that we were talking about. But the legend shows that basically the white, if you have a white area within a county, it's missing insignificant data. The lightest color is going to be lower than the state rate. The orangish color are rates that are at the state rate, and the darkest color are substantially above the state rate. And when we talk about substantially above the state rate, consequences, so like the mortality, it's going to be 50% or higher than the state rate. And for safe survey data, so anything that's taken within the survey is going to be 25% or higher than the state rate. So the next, please. Okay, so now we're going to start with the consequences. So the first thing we're going to come to are the alcohol related indicators for New Mexico. So if you look at these, what I put on here are for the last few years of aggregated data for chronic alcohol injury, all alcohol related deaths, CLD hospital, and motor vehicle related crash deaths. And if you see here, in 2020, like the major increase occurred with all alcohol related deaths in the gray column, and in the furthest blue column, which you see, which is above the 80, it's probably at 98, which is CLD hospital discharges. So it looks like what we're experiencing is that our alcohol related hospital discharges where people are showing up at hospitals. We know that chronic alcohol-related injuries typically are I'm freezing up a lot. Is that what's happening for everyone, or is that what's happening across the board?
On our end, you look good, Alicia.
Okay, good.
Nothing's frozen.
Okay, so that was just someone else. Okay, great. So it appears that the alcohol-related chronic I feel like I just got completely thrown off. Sorry about that. But what we see here is that everything has kind of increased in those last couple of years in 2016 to 2020. But the biggest increases were obviously in the CLD hospital discharges and in the all alcohol related deaths when we look at alcohol related indicators. So let's move to the next slide, please. All right, so when we look at alcohol-related deaths in New Mexico from 2016 to 2020, so alcohol-related deaths in New Mexico have always been about twice the rate of the national rate. And when we look at the rates and how they have increased, I mean, it's been about a 17 or 18% increase from 2019 to 2020. And we'll look at this in the next slide, but chronic and acute rates were higher than the national rates, and all alcohol related death rates were higher in McKinley and Rio County. And when you look at the profile, I don't have a lot of county data specific in this presentation, just because we were limited on the amount of time that we were able to present. But the profile does provide specific county level data, and in this particular situation, McKinley and Rio counties were both twice the state rate. And they've always been consistently higher than other counties in New Mexico. We also look at demographics. So American Indians, followed by Hispanics, had the largest rate of alcohol-related deaths, and males had the highest rates when compared to women across all race and all other racial ethnic groups. So I think it was more than 2.5 times greater. So something just to keep in mind whenever you're looking at things within the profile of what you can look at. You can look at all kinds of different demographics. So just know that what I'm showing you today is just kind of the bare minimum, but just know that there are other demographics that you can see. So next slide, please. All right, so this is what I was talking about the acute and chronic alcohol-related deaths. So the rates of chronic alcohol-related deaths have been greater than those of acute in New Mexico forever. We talk about chronic conditions. We talk about things like cirrhosis, and when we're talking about acute conditions, we're talking about things like falls. So if you're more curious about what else we're talking about, we do have examples of that within the profile as well. But when we compare these, males are more than 2 times higher than females to experience chronic conditions as opposed to both chronic and acute. So I think chronic, like we have chronic conditions of 53.9 for males compared to women of 26.6, where acute 47.7 and 16.7. So, I mean, when we're looking at males versus females, it appears that males are more prone or more prevalent to having alcohol conditions or alcohol alcohol-related injuries. So just something to keep in mind whenever we're looking at how we can address alcohol in our communities. The prevalence of alcohol-related death was highest among American Indian males, with 166.5, with a rate of 166.5 per 100 population across all race, ethnicities, and all sexes. So that's really high in our community. The prevalence of acute injury alcohol-related deaths was also highest among American Indian males, with 105.2. The highest rates of chronic alcohol death were those 65 plus, and McKinley and Rio-Aruba counties both had the highest rates of chronic and acute rates that were more than twice the state rates. So what we're looking at here is, how do we look at the counties, and how do we look at the population, and how can we use this profile to really kind of help us address some of the issues that we're experiencing within our state with some of the alcohol problems that we're having. So next, we're going to look at some of our drug overdose issues. So in New Mexico, between the years of 2016 and 2020, we know that in 2020, there was a bigger increase than we had seen in many years. However, it's not necessarily having to do with the pandemic, but maybe more having to do with the increase in fentanyl. We won't really know what that's related to, maybe for some time to come, just kind of based off of we need some time to kind of look at what all has been happening. But it has been notably higher. The overdose rates have been notably higher in the United States in 2020. And we had a 32.4% increase in overdose deaths from 2019 to 2020. We went from 605 deaths in 2019 to 805 deaths in 2020. So just a little bit more information here. In a single, the single year, we had a single year rate of 39.7, and the US drug overdose rate was 28.3. So we're higher than the national drug rate. 5-year aggregate rates, something to just kind of keep in mind. Male overdose death rates were approximately 2 times more than that of women. Hispanic males were higher in the age group of 25 to 64, and Black women ages 25 to 64 had the highest rates among women. And our, Rio-Aruba County had the highest death rate in New Mexico, nearly 3 times the state rate. And Bernalillo accounted for almost 40% of the state's overdose deaths. Roughly 1/2 of the counties in New Mexico had rates equal to or greater than the US rate. So we're looking at some overdose issues that we're hoping to make some changes, but I think that we're addressing it as best as we can. And I think that by, at this level, being able to look at what really is occurring, which are the next slides that we're looking at, which drugs are the substances that are impacting our communities, are going to be probably the most important. So here we're looking at the methamphetamine. So in this slide, previously, methamphetamine, we only had a methamphetamine section, and then we had an unintentional overdose. This year, we started a couple of other sections. So this, I assume that this graph will probably move at some point, but I think it's important just to kind of keep this graph where it was at this point, just so that we can kind of use it as a talking, I guess, talking point. But do you see, so the red line is fentanyl, and the green line is methamphetamine. And if you look at it, it's clear that we see that methamphetamine is still a really huge problem, and that fentanyl has really taken off. If in 2020, methamphetamine, when we get to the polysubstance section, you'll see that methamphetamine was still the largest contributor to overdose deaths. And we included a fentanyl section because of what we're seeing here on this graph. And but methamphetamines have still been, in this particular time frame, been the largest contributor to overdose deaths, which were a rate of 10.8 per 100,000 population. And males were more likely to experience an overdose death compared to women. There were methamphetamines with opioids, where when we get to the polysubstance section, which, I mean, I think that, you know, including some of this new stuff has been really great, where we're able to really kind of see where we're able to see where the combination of multiple substances have probably been more of a contributor, has been beneficial, I think, or will be beneficial to us. So, and then including with the methamphetamine overdose hospital discharges, combining this with this particular part of the presentation, where we see that hospital discharges for methamphetamines have increased also. So we see that increased 20% or 12%, and that males also were the most likely to present at a hospital for an overdose, and that Blacks were the ones with the highest rates, and among females, whites had the highest rate. So we just, you know, being more familiar with what is happening in the community, I think this gives us a clear perception of what is happening. So the next slide. All right, so fentanyl overdoses. So this is a new, fentanyl is a new section for the profile. I hope that everyone finds this section really helpful. And after you've had a chance to look at it, maybe send me or Robert a note. Our email addresses will be available at the end of this, and let us know what you have found most useful. So there are single year rates here shown on this slide. This is the chart 1 that you'll see here. It's obviously you see that the OD rates where fentanyl was involved tripled from 2019 to 2020. It went from 6.7 to 16.0, which obviously prompted the inception of this particular section in the profile. 5-year rate showed that men were twice as likely to experience a fentanyl-involved overdose death. And when looking at age groups, the 25 to 64-year-old age groups and race ethnicity, Blacks followed by Hispanics had the largest prevalence of overdose, where fentanyl was involved between the years of 2016 and 2020. Again, Rio Aruba County had a rate that was more than 2 times the rate of the state for fentanyl overdose deaths. Also, when we're looking at emergency department visits for opioid-related overdoses, a single year, which is what you're looking at in this particular chart here, emergency department visits decreased in 2020. So this could show a couple of things. This could be because people were afraid to go to the hospital because of COVID. I mean, we're not really sure why necessarily that happened, but that is what the data showed. But 5-year rates showed that males were 1.5 times more likely to present at a hospital for an opioid overdose, and that the males aged 25 to 64 had the highest rate of hospital discharge for opioid overdose. And also Rio Aruba County had nearly 3 times the state rate for an ER visit for an opioid overdose. Next slide. God, this is kind of blurry is it blurry for everyone, or is it blurry for me?
It's a little bit blurry.
It's a little bit blurry. Well, I'm going to tell you in the profile, it is not blurry. And so we did a, the profile is, hey Jay, the profile is not available in a printed version this year, but it is already available online. So if you don't have it, I will send you the link to it. And unless, Andrea, have you already sent out the link to everyone?
I have not, but I can do that now in the chat. Oh,
Great.
Haley's on it. Haley got it.
Great, great. We do have the link available, Jay, so we'll go ahead and send that out to everyone. It has been published. So the polysubstance is another new section this year, and I'm going to tell you that we went as a team. We really worked on these new sections pretty hard, I guess, together. And even Michael was involved in a lot of these, and he actually worked on this one with me quite a bit on what other things we could include. And so we got a lot of extra input, and so this is what we settled on this year. And so if anyone has anything extra that they want to put in for this one, just let us know. I'm sure that we can probably, you know, talk about how we could make any changes. I mean, this was like I said, this was a new section this year, and we really were trying to figure out how we could show polysubstance as best as possible. And if you look at this, so how we're showing this, if you look across the top, it is the single substance for a 5-year count. And then if you look down, it is the second drug. And then the down all the way at the bottom, it's with a third drug or more. And then, you know, we have at the bottom where it said alcohol involved. And the reason is because alcohol was included as one of the top 10 drug involved deaths this year. And so in a meeting I had with Michael, actually, he was like, can we please, and I say Michael Coop, he asked, can we please include alcohol in this? So that is how that was included in this. And I think it was really important too. But we see that, you know, fentanyl is increasing quickly, although we see that methamphetamine for the 5-year period is showing that it was the highest. But if you really look at the next year, my guess is that you'll see in 2021 that it may surpass. So if anyone has any questions on how to read this or any additional questions on the polysubstance, please reach out to our team and we will help. But we did think that this was the best way to kind of like put this out there initially, just to kind of introduce a polysubstance section. So next slide, please. So adult mental health. All right. So I put these 2 indicators together, even though suicide falls under consequences, which is mortality, and frequent mental distress falls under survey. Suicide death is increasingly a leading cause of adult and adolescent death, probably. it's there's a host of measures that exist for assessing mental health, but one of the major measures has been looking at well-being and the frequency of which people like look at how they experience everyday or poor mental health. So, and in the BRFIS, this is a measure based on a single question, like how many days during the past 30 days was your mental health like not good? So respondents who report that they experienced 14 or more days that their mental health was not good are classified as experiencing frequent mental distress. So I put these two together because I think that they really are related. And if you look, so the suicide rate in New Mexico has remained consistently higher than the United States. Males are more likely to complete suicide. Whites are more likely to complete suicide. That 25 to 64-year-old age range are the range that are more prevalent. And we, 19 counties in New Mexico were above or at the rate for suicide in the years 20 to 2016. So when we then flip to what does our survey tell us about frequent mental distress? I mean, that's what's kind of the precursor for our suicide. And so what it's telling us is that, we are for frequent mental distress, we are slightly above the US rate, and that females are reporting more frequent mental distress than males. Our females are 16 at a rate of, or a percentage of 16% versus 12%. That's what they are reporting. And that that whites, once again, are the highest percentage. And that, we have the highest rate of suicide at 25 to 64, but that 18 to 24-year-olds are the ones that are experiencing the highest rate of frequent mental distress. And of the 19 counties that are having having the highest percentage of suicides, when we look at that, like 13 counties in New Mexico have a rate or have a percentage that's higher than the state for frequent mental distress. So those two things really are consistent. So when we're looking at how we're gonna maybe do some prevention, looking at those two things together would be really helpful. So the next slide. All right, so adult consumption. So in just to be clear, in 2020 we had the BRFIS, but in 2021 we did not have the YRRS. So the BRFIS is the adult survey. The YRRS, which is the youth survey, we will be done in 2021, or was completed in 2021. So we will have that data available for you probably later this year, hopefully, and will be in the next profile. But so this is going to be survey data based off of what people report about their own using. So adult binge drinking, if you look at it from the last few years, from 2014, 16, 18, 20, it has, gone up in 2020, we're looking at, between, an increase to 15.7 for binge drinking and 6.7 for adult heavy drinking. Males are twice as likely to report binge drinking, and Hispanics had the highest percentage of binge drinking. And among women, it was American Indian women. The highest risk for binge drinking was in the 18 to 24-year-old age group. And heavy drinking, which is more than 2 drinks on an average day for men and 1 drink on an average day for women. And I guess I probably should have said for binge drinking, I think it's 5 drinks for men, 4 drinks for women. I think they changed that. But males were more likely to report heavy drinking and than women. And among males, Blacks had the highest percentage of heavy drinking. Among women, whites, the greatest risk for binge drinking was in the 25 to 64-year-old age group. And that 1/3 of the counties in New Mexico are equal to or above the state percentage for both adult binge and heavy drinking. Sirocco County was the highest for both binge and heavy drinking. And for adult drinking and driving, so that definition basically drove after perhaps having too much to drink, or at least having had too much drink in the last 30 days. Someone just sent me a note and it threw me off, sorry. But it looks like that has doubled in 2020. So next slide, please. All right, so adult smoking. So adult smoking, we know that, so the question is kind of smoked 100 cigarettes or more in a lifetime, or smoked 100 or more cigarettes in a lifetime and smoked cigarettes in the past 30 days, if I remember correctly. But the prevalence of smoking, I put these 2 things together to, instead of keeping the deaths separated, just because I think these 2 are closely related. Adult smoking has decreased since 2020. Males were more likely than females. Blacks more likely than any other racial group. 25 to 64-year-olds, and we're right at the U.S. rate versus the state rate. And similar with the smoking related deaths. So I got a note that I have to kind of move up, so we're almost done. So the adult e-cigarette is new this year. So looking at this one, if you notice the little dot under the 4.9, that is that's the new adult e-cigarette, because it's new to the purpose this year. If you notice, males are more than 2.5 times more likely to use e-cigarettes. Hispanics, males had the highest prevalence, and across all age, race, ethnicity, 18 to 24-year-old age groups, there was a 3 times more likely to use e-cigarettes. So next one. So this one I really wanted to get to, and I'm hoping that if we have a couple of minutes, this is the last slide on here. So this is the adult cannabis, and Haley is on here too. These questions have been on the Burfest for a few years. So we were able to include this one in this profile, although it wasn't something that we had necessarily been asked to do. But the chart shows that more than half of the respondents claimed daily or nearly daily use of cannabis, which is about 20 to 30 days, 20 out of 30 days, I guess, or 20 to 30 out of 30 days. And the highest percentage of reason for use was 44% for medical. And that was just slightly higher than the next, which was recreational and medical combined, which was 36%. So the overall, 18 to 24-year-olds had the highest percentage of cannabis use, and American Indian males percentage of cannabis use was 22.6, and white females at 14.4. Haley, I don't know if you have anything you want to add on this. I know that you have done a ton of research on it. And the next slide is just basically my information, Robert's information. If anyone has any questions, I know that I'm sorry I started cutting it short at the end, but I got a note that I was running out of time and I wanted to make sure I got to the end. Previously, we had a heck of a lot more time to talk about the profile. There is a lot of information in there, so I hope that everyone gets an opportunity to look at it. If you don't, or if you have any questions, please contact me or Robert. We'll be more than happy to help you navigate it, or anyone on our team will be more than happy to help you navigate the profile. There's a lot of information in there. And if you have any questions or anything that you would like to see new, please let us know that too. And we hope that you enjoy the new sections.
Alicia, thank you so much for your presentation. And thank you for all the work into the EPI profile. It's a critical piece in how we plan for appropriate services and community. So we really appreciate that. We will make sure that everybody gets the link to the EPI profile. And thank you so much. Were there any other questions in the chat? Just a lot of gratitude and thanks, Alicia. So with Alicia ending her presentation,
It looks like Pamela's Zoom was cut out, and here she comes. She's logging right back in now.
my apologies. So next we're going to go on to the presentation by SAMHSA with Shannon Hastings and her team, Chase Holloman, Riley Lynch, and Lauren Thompson. We're very thrilled to have them join us today. Their presentation is on prevention and harm reduction, a partnership across approaches. Thank you all for joining us today.
Hi, everybody. Good afternoon. Thank you so much for having us. Is someone going to share the slides, or should I?
We can bring those up for you if you'd like.
Okay, and Chase is still in attendee mode. Okay, great. Thank you. Good afternoon, everybody, and welcome to our presentation. Today, we're going to talk about the role of prevention in harm reduction. And I am presenting with my colleague, Chase Holloman. We are from the Center for Substance Abuse Prevention at SAMHSA, which oversees, I think, 5 of the grants in this portfolio that you're meeting about today. So we are excited to talk with you about harm reduction, which is a newer priority for SAMHSA and the federal government. So we're excited to talk about that today, and hopefully you can think about how to incorporate harm reduction into your programs. Next slide, please. So like I mentioned, Chase and I are both public health advisors in the Center for Substance Abuse Prevention. I'll let Chase introduce himself for a minute, but to introduce myself, I come from New York. My background is in public health and health education. And my role at SAMHSA is as a project officer and also as the harm reduction program lead for our new grant program, which I'll talk about in a little bit. Chase?
Thanks. Hey, everyone. Like was mentioned, my name is Chase Holloman, a public health advisor in the Office of Prevention Innovation and the harm reduction lead. My background is in clinical social work. Before coming to SAMHSA last October, I founded and directed a harm reduction services program that doubled as a clinical training site for students getting their health and human services degree. Glad to be here.
Thanks, Chase. Next slide. We are also joined by the government project officers overseeing the grants that you're meeting about today. So I'll let Lauren and Riley introduce themselves, and could you just say which grants you oversee?
Hi,
Lauren.
everyone. I'm Lauren Thompson. I'm a public health advisor in the Division of Primary Prevention in CSAP. I support grantees in New Mexico as well as Texas right now. I'm a project officer for the Partnerships for Success grants as well as the Stop Underage Drinking grants. And I'm based here in Washington, D.C. Riley, I'll turn it over to you. Thank you for having me today.
Hello, everyone. I am Riley Lynch. I'm also a GPO with CSAP. I oversee grants in New Mexico. I have the SPIF-RX grant, the PDO grant, and the FR Care grant, and I am based in Charlotte, North Carolina. It's nice to see you all. Glad to be here.
Thank you, Riley. Thank you, Lauren. So Riley and Lauren's role as a project officer, for folks who might not know, is to oversee the programmatic aspects of the grant. So we work closely with Tone and her team to oversee the grant, make sure that the reporting requirements are met, and any other grant deliverables. So if you see Lauren and Riley's names in emails, this is their face, and they are the project officers for your grants. Next slide. Our goal for today is for you to have an increased understanding of harm reduction from the highest level with the current administration's goals for overdose prevention and harm reduction, to learn where harm reduction fits in the continuum of care, and to know how harm reduction is already part of our daily lives, and discuss some of the practices that you may already be familiar with or doing every day, and also SAMHSA's role and equities with harm reduction. Next slide. Before we get started, we like to do a quick poll to gauge the audience's familiarity with harm reduction. So please select whether you are not at all familiar with harm reduction, slightly familiar with harm reduction, or very familiar with harm reduction. Great. So we've got more than half of folks are very familiar with harm reduction, but still about 40% that are still learning, which is great. So we hope that everybody here will learn something from our presentation today, and we'll get right into it. Next slide. Over the past year, the Biden administration has developed a 4-part overdose prevention strategy based on primary prevention, harm reduction, evidence-based treatment, and recovery support. Addressing the overdose crisis requires a multifaceted and integrated approach. So that is why we have these 4 prongs. And the administration's ongoing efforts to address the overdose epidemic is a key pillar for the first time in the government's approach to reduce overdose deaths. And while SAMHSA has been doing overdose prevention work for many years, harm reduction is a new strategy for us. And we are eager to learn from the field and from our grant recipients ways that you are already incorporating harm reduction and new ways to incorporate harm reduction in our work. Next slide. The overdose prevention strategy emphasizes that evidence-based and promising harm reduction strategies reduce risk associated with drug use, including overdose and infectious disease transmission. Examples include fentanyl test strips, syringe service programs, and naloxone distribution. Harm reduction also connects people to important health and recovery support services and supports an environment that challenges community stigma towards people who use drugs. Next slide.
Thanks. So to get us started, the background is very quick, and this is the why. I think we all know that this is a problem for the first time between June 2020 and June 21. There's an estimated 101,000 people who died of an overdose. And this is the why of our work. And I think that's important. My why is I'm tired of burying people who I love and care about. Next slide, please. So what is harm reduction? I think it depends who you ask. And there are a lot of definitions. So harm reduction is not being defined for the first time by SAMHSA. Harm reduction is not new. It's been around for decades. Harm reduction is new to SAMHSA. And how we're currently defining it is this definition up here, which is a placeholder for now that is from the ONDCP drug strategy that was recently released. We're working on a definition with stakeholders as part of a larger framework we'll talk about later. And then here I've just got a word cloud that includes words that are typically associated with harm reduction. And then I like to use an analogy. The best way I've heard it explained, at least as a public health approach, is like this. And that's that I imagine most people that are on this call right now have rode in or driven an automobile in the last week. And I imagine that most people in this virtual room right now know someone who has been seriously killed or injured in an automobile accident. Driving is dangerous. It's one of the most dangerous things that we do, and a lot of us do it nearly every single day. And with this knowledge, I imagine that most of us are still going to ride or drive an automobile in the next week. So harm reduction is a seatbelt. Harm reduction is traffic laws, an airbag, bumpers. They are things, public health interventions that we have designed to reduce the harm of a dangerous activity. And driving and using drugs are a lot different. But the practical reality is we would be hard pressed to name a society since the beginning of time who did not use drugs. So it's the simple acceptance of that and reducing the harm. Next slide, please.
To echo what Chase said, here is a great slide that was developed by one of our staff members. It's examples of harm reduction across many areas of life. And I really love this slide because it shows really easy examples of harm reduction and things that I do every single day. Next slide. This is a quote from a book called Undoing Drugs by Maya Salovitz. The quote, "Pragmatism is at the heart of harm reduction, which requires dealing with the world as it is, rather than as you wish it might be." This kind of speaks to what Chase was just saying, that we can agree that the world might be a better place if there were no drugs, alcohol, and addiction, but that's not the case, and it honestly never will be. So substance use is part of our world, and we can't ignore it, and instead we need to provide practical and pragmatic solutions. Next slide.
So I think it's important to give a little history and background and acknowledge the history of harm reduction. As I mentioned, harm reduction is not new and is new to SAMHSA. This picture was generously lent to me by a friend at the Comer Family Foundation, and it's a picture of the original harm reduction working group that met around 1993 or a few times, and this group became what is now known as the National Harm Reduction Coalition. And why this group met is in a response to be quite frank, racist drug policy and the HIV/AIDS epidemic. Government slow action as a response to this resulted in people responding, some brave activists who lived with HIV and AIDS, members of the LGBTQ community, came together and started to save their own lives. And part of that was handing out syringes to people who use drugs, knowing that it could help spread the transmission of HIV. And this happened for the first time around 1988, at least in the United States. And then by 1993, they had formalized and became this work group. by 1996, harm reductionists became the first people to do opioid education and naloxone distribution, which is quite a long time ago to think about that they were doing this. And then in 2021, now SAMHSA is supporting harm reduction. Next slide, please. So I mentioned the issue of racism as a catalyst for harm reduction. This is a publication that SAMHSA has released, and the link can be found down at the bottom. And the reason I post this is there is a quote from it that I really think does a great job of summing this up. And it says that 3 decades ago, when opioids and crack cocaine were devastating Black African-American communities, the national response was the war on drugs. This resulted in widespread incarceration of drug users and disruption of primarily Black African-American families and communities. This population was criminalized for drug-related offenses at much higher rates than white Americans, and this has had lasting effects to the present day. Next slide, please. Thanks. So when framing harm reduction, as we think about this and how it works practically, we're framing it in 3 different ways, right? So harm reduction entities, these are harm reduction organizations like we talked about before, right? And these are led by people with lived experience, the community-based, very grassroots, very much rooted in peer support and mutual aid, meaning people with lived experience taking care of people with lived experience. Have been doing harm reduction for a while. And the important part to know is that we're just asking that they have a seat at the table, for prevention coalitions, treatment coalitions, all of the folks that are sitting talking about how to care for people who use drugs. And then the next we have is harm reduction services. So these are things that people are probably familiar with: syringe services programs, fentanyl test strips, opioid education, naloxone distro. And then I put some other things that aren't often thought of as harm reduction. One is a drug user health hub, which is a model where folks who make it to a harm reduction outreach site because it's accessible and low threshold can receive medical services there or easily be navigated to healthcare services. And then full case management, which often occurs at harm reduction organizations and diversion programs. And then approaches, which is for people who are not providing services, aren't an entity, but learning how to integrate harm reduction into their work. And this is what we do after someone's first use. I put here, just say no with a K and N. This approach is about educating people and empowering them to make choices with that education, being low threshold, no wrong door, and celebrating any positive change. Next slide, please. So I like to challenge some harm reduction myths that I hear often. And this first one is that harm reduction enables people and prevents them from reaching bottom. Well, this actually isn't a myth. And I appreciate this, and that's that harm reduction enables people to continue living and breathing, enables them to make healthier decisions, enables them to start making positive change in their life. And it does prevent them from reaching bottom. And I think because now, more than ever before, bottom for people is death. And there is no positive change that happens after that. Harm reduction sends the wrong message and encourages drug use. There is no evidence that harm reduction programs and communities increase the rate of drug use. Harm reduction discourages abstinence. This is a myth, and often these ideas are forced as a dichotomy when they're not. Harm reduction includes abstinence. In fact, it's the path of least harm. And then people always want treatment. So this myth is tied in with the former. And this is that harm reduction does not encourage nor discourage abstinence. It encourages the goals of the people harm reduction serves. Next slide, please. So going back to that point, this is data from the NISDA in 2020. So a lot of people are familiar with this, and that's that almost every year it comes out that 1 in 10 people with a substance use disorder who needed treatment received treatment. So 90% of folks with a substance use disorder did not receive treatment. What is often not reported, next slide, is that of that 90%, 97.5% of them did not feel that they need treatment. And this is not an indictment of those people. This is an indictment of the services that we currently have to offer. So not 90% of people are not receiving services, and 97.5% of those folks don't feel they need them. I imagine that they would like some positive change in their life. Harm reduction is our opportunity to meet folks where they are and provide services to the people not receiving them. Next slide, please. So this everyone else who I'm talking about, the reasons for this, I'm going to try and go through this because for time's sake, people have reported being treated poorly by the healthcare system. As long as I can be arrested for using drugs, it is going to be hard for me to admit to someone I'm doing them, to get help. Negative experiences, lack of person-centered options and evidence-based care, particularly opioid use disorder. Only 1 in 3 providers in the United States are providing the standard of care, which is agonist-based treatment like buprenorphine and or methadone, and transportation. Next slide, please. So how harm reduction helps with this is by providing low-risk barrier strategies, meeting folks where they are, spending time to build a rapport and trust. And by meeting folks where they are, I mean that they are truly community-based and community-driven. The community has a stake in them because they've been part of the process of developing, implementing, and evaluating the program, and celebrating any positive change. It promotes transparency and openness. If I am not kicked out of your program for using drugs, then I'm a lot more likely to tell you when I did use drugs instead of keep it from you. Privacy and meaningful inclusion, and also just the fact that people can choose not to submit their information instead of going through a 3-hour comprehensive clinical assessment to access services. Next slide, please. So this is, a lot of people see this is a pyramid that Maslow maybe borrowed about the hierarchy of need. And this slide is just to show that a lot of times we expect self-actualization from folks through therapy, counseling, or whatever else. And people are way down here and do not have their needs met with physiological needs. And for folks with opioid dependence, this includes agonist therapies. Otherwise, people are not in a state of homeostasis without opioids. Next slide, please. Just to show that these ideas are not new, very similar with a lot of things that we do now, motivational interviewing, stages of change, non-maleficence, just supporting autonomy and collaboration. Next slide, please. And then, as I mentioned earlier, harm reduction allows people to always be in a system of care, and it is not outside of prevention, treatment, and recovery. These are all things that have overlap, and the more that they coordinate, the more people do not get lost in the system, like the 90% of people currently lost. Next slide, please.
We like to think of substance use on a continuum, including people who do not use substances at all, experimental use, and social or recreational use. Even the diagnosis of substance use disorder is on a spectrum ranging from mild, moderate to severe. As we will see, harm reduction practices are applicable throughout this spectrum. Every space between these types of use is an opportunity for harm reduction as prevention, and there's a long road between someone's first use and a severe substance use disorder. Earlier intervention can prevent someone from ever needing treatment or developing a severe substance use disorder. Next slide. Prevention and harm reduction can also be seen on a continuum and have overlaying goals. First of which would be to prevent or delay the initiation of substance use, also known as primary prevention. Next is to intervene as early as possible once a person starts using substances. The goal in this stage is to reduce the chances of the person experiencing or person using substances to develop a substance use disorder. The far side of the continuum shows the goal of preventing deterioration or death. Harm reduction practices, like I said, can be seen across this continuum. Next slide. Here are some of the goals that we have for harm reduction as prevention. Reduce the spread of infectious diseases, including HIV and viral hepatitis. This could be through safer sex practices, condom distribution, screening, testing, sterile injection supplies, and wound care. Reduce stigma and increase access to health services. This could be low threshold MOUD, alcohol prevention programming at colleges, which actually was my first job ever related to prevention and harm reduction. So I was doing outreach at my college, talking about safer ways to consume alcohol, how much is a shot, how many ounces are in a beer. So these are ways to reduce stigma, incorporate harm reduction in non-traditional ways. Also increase referrals to psychosocial support services, a common activity of community-based programs, especially those funded by CSAP. Increase knowledge around safer drug consumption and sexual health, increasing access or offering fentanyl test strips, naloxone training, drinking guidelines, harm reduction advisories. Also, bars are considered harm reduction. I didn't think about it this way until Chase told me once, and I was like, oh yeah, that makes total sense. Serving limitation, hours of operation, offering food, and also being in a contained space. Lastly, improve health and well-being. So that could be the alcohol age requirements, having a designated driver on staff. Those are all harm reduction strategies. Next slide.
Thank you. So just to talk a little bit about fentanyl, I heard some of this in the last presentation, but this is very, very important. So the reason for the the overdose crisis that we have right now is largely due to fentanyl. And we're not talking about pharmaceutical fentanyl that you might get at a provider to treat acute pain, but illicitly manufactured fentanyl. And not just one illicitly manufactured fentanyl, but dozens and dozens of analogs of fentanyl that do different things. The reason that this is such a problem is not only cross-contamination with other substances that for people who are opioid naive can prove deadly immediately, but because they have different effects. And people cannot eyeball their drugs anymore like people have in the past. It is just incredibly dangerous. It's micrograms to grams, and this is what is in the drug supply, especially on the East Coast. And I want to mention that we did some site visits on the West Coast last week, and we know that fentanyl has reached the West Coast. However, I don't know that it's reached in the way that it has the East Coast, and it's important to know fentanyl test strips and drug checking is incredibly important because of these different analogs can have different effects. And by knowing what's in the drug supply, people can warn people who use drugs about certain batches or bags that may be more dangerous than others. Next slide, please. And just to elaborate on that, and we know that works the same way we know fentanyl test strips have been shown to change people who use drugs behavior when they find out that drugs do contain fentanyl and make healthier choices. Certain service programs are essential infrastructure. In 2019, certain service programs were the source of 81% of all naloxone distributed to lay people in the United States. So incredibly important to get naloxone directly to people who are directly impacted by this and most likely to be the first responder in an overdose situation. Also, people who engage in certain service programs are 5 times more likely to enter treatment. And interestingly, 2.5 times as likely to be retained on MOUD at 12 months if they start MOUD. So once again, being that access point, that low threshold access point. Next slide, please. So certain service programs prevent and reduce transmission with MOUD, medication for opioid use disorder, and certain service programs together. It can reduce HIV and hepatitis C transmission by 74%, which is incredible. It also prevents soft tissue infections like endocarditis and other blood-related illnesses that can prove deadly. Next slide, please. Shin, are we gonna have time to go through this? What do you think?
I don't think so, unfortunately.
I don't think so either. Next slide, please. I was going to briefly tell you about the program that I come from that puts this into action. And TLDR, the short of it is that it filled a hole in the community and connected providers from faith-based communities all across the community to help save lives and distribute naloxone and life-saving tools. Next slide, please. And these are just some photos from that. Next slide, please. And if you want to learn more about this program, you can visit gcstop.uncg.edu. Next slide, please.
Thanks, Chase. So here shows SAMHSA's harm reduction equities. So we have the harm reduction grant program, which is a $30 million 3-year grant program awarded through CSAP in May of this year. The Division of Targeted Prevention, where Riley and I work, oversee this grant program, and there were 25 grant recipients. The Harm Reduction Technical Assistance Center is a partnership between CDC and SAMHSA to offer technical assistance support through technical assistance providers. This is available to anybody, to the public, so we encourage you to reach out or at least bookmark the Harm Reduction TA Center. Chase, if you could post that in the chat, please. Like I said, this is a free resource and support for anybody, not just for syringe service programs. So if you're looking for information on incorporating any of the harm reduction strategies we talked about today, please feel free to reach out to the TA Center and they will be more than happy to help you. Lastly is the Harm Reduction Stakeholder Engagement and Framework. And this is, the framework document is like a roadmap or recipe, as Chase likes to say, which includes the harm reduction definition, pillars, principles, and best practices as identified and discussed by harm reduction stakeholders across the country. So it's really embracing the harm reduction strategy that we've talked about today, being community driven and with people with lived experience and expertise in harm reduction. So that will be a document that SAMHSA publishes, like I said, in collaboration with stakeholders. Next slide. I wanted to show you the harm reduction webpage, which is on SAMHSA's website. And I invite you to visit it to learn more about SAMHSA harm reduction's place in and among prevention, treatment, and recovery, and our current and future support for harm reduction. Next slide. I'm going to wrap up in just a minute, but I wanted to share that some of the programs in the Division of Targeted Prevention's portfolio have harm reduction elements, even though it's not the harm reduction program. So that is the FR CARE grant, SPIFRX, with which some of you are grant recipients for. So some of the activities that you're already doing have harm reduction elements in them, and you're already doing that. Next slide. I just wanted to give a brief overview of the harm reduction grant program, and the purpose is to support community-based harm reduction services to enhance overdose prevention and to help control the spread of infectious disease. So this is done through incorporating harm reduction strategies such as sterile syringe distribution, low threshold buprenorphine, naloxone, fentanyl test strips. A lot of our not a lot, maybe like a good portion of our grant recipients are doing harm reduction vending machines, which is a new approach that we're really excited to learn more about and to support. Next slide. This is what the Harm Reduction Technical Assistance Center website looks like that I talked about earlier. So like I said, this is a free resource for anybody in the country providing or planning to provide harm reduction services. And lastly, next slide. We would like to see how familiar you are with harm reduction now that we've given our presentation. Hopefully you have learned something, but how would you rate yourselves with your familiarity with harm reduction? Oh, yay, people are very familiar and slightly familiar with harm reduction. So that is great. A little bit of evaluation in our presentation. We can't forget the importance of data. So thank you all. Next slide. Okay, so thank you for attending today's presentation. We're going to open it up for Q&A, but I did want to highlight SAMHSA's National Helpline, which is a confidential, free 24-hour a day, 24-hour a day, 365-day a year informational service for people facing mental health and or substance use disorders. So if you need to call the helpline, please do that. We did not update this slide because it still has EAP on it, but maybe your organizations have EAP as well. So we would like to open it up for Q&A if anybody has any questions for us.
Andrea, are there any hands up with questions?
There are not.
We have a thank you so much. I would like to take a moment to thank Shannon, Chase, and Riley and Lauren for being present here today and for the presentation, and to really show us how we can leverage and work together amongst program with prevention and harm reduction. So we appreciate your support. This was wonderful. Thank you so much for taking the time to share this presentation with us today. Another thank you, so much gratitude for you all being here today.
Great, thank you all. And if anybody has any questions afterwards, you can send them maybe to Andrea or Pamela. I'm not sure who would be the point of contact from OSAP, but you guys can forward the emails to me and Chase.
Thank you.
Great, thanks everybody. Have a nice day. Bye.
So everyone, it is now 12:03. We didn't get to do our stretching activity, nor our quiz with Jay to win coloring books. We'll see how we fit that in to the breakouts tomorrow, maybe. I wanted to remind everybody of your topic specific, your grant breakouts tomorrow from 9 to 12. It's SINAR. 8 to 9 is the SPIF RX. 9 to 10 PDO. I look forward to seeing my team tomorrow. 10 to 11 is the PFS 2020. 11 to 12 is the FR CARA. And then our afternoon topic specific breakouts tomorrow are option 1, adaptations for Hispanic communities. Option 2, anti-stigma messaging and approaches for stigma prevention. And option 3, protecting youth mental health. Thank you so much for your time and your patience today. Look forward to seeing you tomorrow. Have a good afternoon.